to CPC. So the case today, just turn it on. The case today is a 55-year-old man who presents with left thigh pain. Our expert clinician today is Dr. Peter McDonnell. And I want to really highlight to all of you that today is going to be a first ever CPC diagnosis. All right, so keep that in mind, first ever. No one, to my knowledge, has ever been diagnosed with this as the final diagnosis at CPC. So let's give a round of applause to Dr. McDonnell, who's going to get it. He's going to get it. I know he's going to get it. And it will be a first ever. This is amazing. All right, so let's meet the expert. This is Dr. McDonnell. I love these photos. So I look nothing like my photo.
I hate this photo.
He hates this photo, all right? But we don't hate him. Okay, so let's meet the expert. A little bit of the, as we call, resume virtues. So Dr. Peter McDonnell is an assistant professor of medicine. He directs the PCIM program here. He's the assistant manager of the primary care medicine clinic. He went to Seattle University for his undergraduate studies in what?
In humanities and chemistry, I double degreed.
Double degree in humanities and chemistry. That's amazing. I didn't know that. Well, I did a double degree in humanities and biology. So, man.
It's like we're twins.
Amazing. Kinship right off the bat. It will dissolve into antagonism throughout the rest of this. 55-year-old man who presents with left thigh pain and maybe some other things, and probably a first time ever diagnosis at CPC. So I just wanted to offer up to you just a moment before we begin on the HPI. Do you have any initial thoughts or frameworks or characterizations for left thigh pain? How might this differ if you were in your primary care role versus an inpatient role? This patient happens to be inpatient. What are your initial considerations?
Well, it's common often for CPC to want to put together a slide with your initial thoughts and differential diagnosis and considerations, but I did not. Because this one-liner did not deserve that. So left thigh pain is usually, most commonly, a musculoskeletal issue. So as far as we know, he might have sprained his thighs. The thigh's kind of also it's a big place. There are like different sides to it. Like it could matter what part of the thigh was hurting and causing problems. That could really help you think about what could possibly be going on. This being CPC, it definitely makes me more worried that this is going to be something that's not too straightforward, because you could be scared, like maybe there's a mass there, maybe this person is a sarcoma, but that'd be too easy. Maybe there's an absence from something that used to be there, like maybe someone stabbed the patient in their thigh. And maybe that's what we're about to find is the first ever CPC diagnosis, acute trauma. But I now am more suspicious for either odd infectious etiologies, malignant etiologies, and autoimmune etiologies. And of course, there's also neurological considerations. I'm really hoping actually that this is meralgia paresthetica. And I'm going to tell him, the inpatient, that his gown was tied too tightly and that was applying pressure, and we just need to loosen that up. And then I'll leave. And we'll see how that goes.
All right. I like it. 3 cheers for meralgia paresthetica. Okay. So moving on to the HPI, you'll get a little bit more information here. Not too much, though. Firstly, the patient described left inner thigh pain without significant swelling. His weight bearing on that side exacerbates the pain. It is tender to touch. The onset of pain was acute, but it was preceded by a subacute history of some muscle weakness and some chronic peripheral neuropathy. He has also had swelling of his left knee, which is also painful. To give you a little bit more context, he recently had a right thigh abscess, which was infected with MSSA and received an IND, intravenous antibiotics, for which he was transferred to BJH. While that event occurred after a fall, the beginning of the left thigh pain is more difficult to pinpoint, but it was mentioned to the hospitalist during the admission. So reframing, we have a patient who was transferred here, had a number of abnormalities that resulted in an escalation of care. He had this right thigh abscess. He's been on antibiotics. This was about a month prior. So he's had an IND, IV antibiotics, and now he's still inpatient. He says, "Hey doc, I have some left thigh pain. The hospitalist note just has at the very top left thigh pain, but it resulted in this considerable workup. How does this change what you're thinking?
Yeah, so I have a couple of thoughts. One of which, again, is, we'll want to characterize some of these things more fully. So you mentioned, like preceded by weakness. It's always good to try to quantify weakness, because that can really affect our concern for so many conditions. The presence of weakness significantly increases your level of concern as opposed to the pain by itself. And similarly, chronic peripheral neuropathy, is this just like a distal toes or possibly fingers neuropathy, or is it unilateral, or what is going on there? And then, of course, with this recent history of infection, that makes you wonder what potentially brought on that right thigh abscess, and could something similar have caused an issue on the other side? And similarly, swelling of his left knee, again, very easily, that could just be something musculoskeletal, where he could have, fallen or something occurred after a fall, and that can cause swelling. You could have a meniscal tear or something like that. But if we are also somewhat worried about infections, we won't be so much worried about like a staph infection, which we would expect to present acutely. But there could be a question, could there be a more subacute, more indolent infection or process?
Great. So thinking, listening to a little bit of what you said there, we know a little bit more now that we have peripheral neuropathy, which is present in the bilateral lower extremities, not upper extremities. He's had some tingling. He's had some kind of paresthetic pain. And then pointing out that, is this a continuous process between the knee and the rest of the thigh? Knee thinking, maybe this is MSK versus infection. He has had a recent staph infection. These are all things that are on my mind. All right. Did he just fall on his way between the bathroom and the bed one night? No, but it's on our minds. All right. So more patient details. So he does have a history of some alcohol use disorder. He has a distant case of pancreatitis, and he has anemia. His surgical history recently, he had this IND of his right thigh. He doesn't have any pertinent past medical family history, no known allergies. Prior to this admission, he was on some Norco. And then his social history, he is married. He smokes a little bit, up to half a pack a day, alcohol every other day, and then occasional marijuana.
Yeah, so a couple things here. One, I feel recently like I've actually been seeing more alcohol use disorder, which has been a little disheartening. Alcohol use disorder can cause a wide variety of manifestations. Obviously, many people tolerate it and are relatively well compensated until they are not. But alcohol use disorder can, for example, cause a peripheral neuropathy. Alcohol use can cause a myopathy that can be either acute or chronic. And so potentially there's some association there. And then otherwise, nothing here is too exciting.
So running through a review of systems, he has noticed some fatigue and weight loss. He does have some oral dryness, but no other vision change. No significant symptoms in his kind of chest or gut. He does have polyuria. And then his MSK, as in the HPI, and you'll learn more from the physical exam, no rash, no skin tightening. He has weakness of the bilateral lower extremities, but most significantly his left lower extremity. And then he has no hair loss or weight change, heat or cold intolerance, and then no other significant mood or behavior changes. And then I have this additional thought slide, but I can just move directly to the physical exam.
Yeah, let's do the exam, yeah.
So the physical exam, normal vital signs, which always reassures me. Significantly on his cardiovascular exam, he does have some traced bilateral lower extremity edema. And then skin, there are no rashes on the skin that we can see. And then I'll just point out that we also learned later that there are no purpura or petechiae. And then on his MSK exam, he does have pitting edema of the left thigh. It's anterior, also lateral. It's very painful to palpation from the left knee all the way to the groin, but there is not any distinct fluctuance there. He has pain on flexion of the left knee, so he has pain in the thigh itself, and then he also has quite extensive pain in the left knee. And then for neuro, he does have left lower extremity strength 3 out of 5 compared to 5 out of 5 in the right lower extremity, although pointing out that he did have some weakness throughout the admission on his right lower extremity as well. Any changes here from what you're thinking? So it's now the whole thigh, mostly anterior, lateral, but there's some medial, goes all the way to the groin. So it seems like the whole thigh is affected.
Yeah.
As well as the knee.
So whole thigh is affected. Whole thigh is pitting edema. And we still have a relatively broad list of causes that could do that, which again, I have not mentioned it, but he could have a blood clot, and that could be causing pain and edema in his left thigh. He could have anything that is causing inflammation. So if he is having, an infectious process, an autoimmune process, any sort of, and this one next to cause pain and edema. Oh, I guess maybe he feels he has a big hematoma there, and that is obstructing venous return, and that is causing him to have swelling there. They've mentioned this pain and edema. They do not note, at least here, that if he has an effusion of his knee that is palpable or determinable. And again, that could just help if we think, when you're looking at a joint, oftentimes they say you should think about the joint down and up. So for the thigh, you could also think how much of this is potentially coming from a knee process, which could be, again, due to kind of any sort of trauma there, any sort of intolerant process there, or infectious process. And then the strength exam would be really, really nice if they broke that down into, like how is someone's hip flexion or, knee extension and flexion, and see if it's just the entire leg.
From what I gathered, it's the proximal muscles that are
the
weaker,
proximal muscles,
especially, his quadriceps. So especially
his quadriceps.
The knee extension.
Yeah, and then proximal muscle weakness is more likely in various myositis conditions, although those would also normally be more bilateral. And here we're still worried that there might be primarily something local to the knee that is causing dysfunction, be that infection, trauma, blood clot, or inflammatory. I don't know yet.
Awesome. So I'll give you some initial labs, and then we'll just have a moment of pause as well. So just pointing out that on his chemistries, chloride elevated, CO2 is a little bit down, so he has a bit of a non-elevated gap metabolic acidosis. His BUN and creatinine are elevated. He's had an AKI throughout this admission. He does have hyperglycemia. It's quite notable, and it was notable earlier in the admission. His albumin's a little low. His alk phos is elevated. And then we see the anemia here, which is normocytic, which he has had throughout the admission. The diff is also normal.
Yeah.
Does this change anything for you right now?
This doesn't massively change anything. With a lot of these things, of course, the big question is how much of this is a change or how much is this chronic? Because at least we know that this is maybe stable throughout this admission. We don't know how this was before he was ever admitted. If his baseline creatinine a year ago was 1.5, then we really don't care at all. If he's having some kind of prolonged kidney dysfunction, that's a little different. Electrolyte normalities aren't crazy. He has a really high glucose. I don't know. Does he just have undiagnosed diabetes? Is there a lot of stress going on from his hospitalization? And that's being added in addition to that. And his albumin is quite low, which does also make us a little bit worried about his chronic nutritional status, which we should also be worried about, generally speaking, with anyone who is drinking a pint of vodka a day, because that can cause people to not eat real food, which is where most nutrients come from. And then similarly, the hemoglobin, the question is this a change? Like, did he bleed several units of blood into his thigh and now it is swollen? Or is it that he has a chronic anemia, which can happen for many reasons, one of which is alcohol. Yeah.
Awesome. Now, it happened the last time that I was in CPC that, one of the things that my discussant said, just in passing, happened to be the diagnosis. And so I see you putting together, this peripheral neuropathy, elevated glucose. And so I just like to put a round of applause together for Dr. McDonnell for diagnosing type 2 diabetes mellitus, first time ever at CPC. Big round of applause. Big round of applause. Everyone put your hands together. So I just want to point out for our teaching topic for type 2 diabetes mellitus today, this is usually a combination of insulin resistance and impaired insulin secretion. It's the most common form. There is type 1 diabetes. We pointed out that the patient has polyuria, has had some fatigue, paresthesias, and then we see that the patient's fasting glucose kind of meets criteria here, is greater than 126. And then we might want to talk a little bit about treating this patient potentially with insulin. although there are a number of other agents that we can use. And there are some long-term complications of type 2 diabetes mellitus that I want to keep in mind. So yeah, there's, I have a lot to think about diet. I often tell all of you about increasing fiber intake as something to help us with type 2 diabetes. But thank you so much, Dr. McDonnell, for standing here and listening to me rant and rave. But indeed, that is not the final diagnosis. But I just wanted to throw that out there. They do have type 2 diabetes.
Carl, can you remind me to blacklist your medical school?
I'll remind you in the future. All right. I went to Harvard. So what additional diagnostics would you want first? How are you framing your thinking? I had withheld from you that this patient had type 2 diabetes, but how would that maybe change your assessment of their myositis? How might that change your assessment of their risks and how you work them up?
Yeah. Well, I appreciate it. So assuming that it has been a chronic untreated issue, then that by itself could, of course, explain things like the peripheral neuropathy that were mentioned earlier. For his more acute problem with this unilateral swelling and pain of his thigh extending primarily to his knee, I do think it is reasonable to image the affected areas. I also, because this is CPC and I do not trust things.
He doesn't trust me. He doesn't trust me, which is merited.
Yeah. Well, this is probably inappropriate because this is not teaching things appropriately. So for the most part, I would just like, oh, we should really examine this area and see what is going on. I was going to also just suggest that we just order about 1 million things just to make sure, because, diabetes was hidden from me. You know what else could be hidden from me? HIV, syphilis. They frequently go together when Carl is here. And okay. But should we start with just some simple imaging or?
Yeah, let's do some simple imaging.
What you're trying to do.
So transitioning here, so we'll go to the initial imaging.
Oh, it was the first thing there.
So on the initial imaging, they did, as you pointed out early on, look for DVTs. So they did an ultrasound of the veins, bilateral. There was no evidence of acute DVT bilaterally. They also obtained x-rays of the femur. It showed no fracture. There was some mild left hip osteoarthritis and a possible hip joint effusion. And then they did an ultrasound of the lower extremity on the left, and they saw extensive edema of the superficial and deep tissues of the left medial thigh, which could be seen in myositis or fasciitis, in addition to cellulitis. And there was no sonographic evidence of a fluid collection at that time. So I know you'd mentioned, the thighs is one of the places where you could miss some blood. There are a number of body cavities where if someone was anemic, you could lose blood into, retroperitoneum being one. However, in this patient, you would think about maybe losing blood into a thigh or a hematoma. And then also in this patient who had this abscess on the right, the team and you would both be concerned, is there an abscess here that we're missing? But there was no evidence of a fluid collection. But we do now have clear evidence of myositis, potentially fasciitis.
Great. Yeah, so and then otherwise it's just kind of non-specific, swollen, and also, of course, great to rule out the DVT. It's still relatively focal, which makes you wonder, like, why is it just affecting that? And there definitely are forms of myositis that present less symmetric than what we oftentimes assume with most, like autoimmune myositis. And of course, there can be local factors, which again can be sometimes just trauma or some sort of, crush injury. Something was affecting man's return that we didn't notice. And they also, mentioned cellulitis. He doesn't have an elevated white count, which of course oftentimes is not present in cellulitis. He did not have, like a massive rash that is generally a hallmark symptom of cellulitis. So that makes us a little bit less concerned for that. I think it makes sense to kind of try to categorize the myositis a little bit by just checking things like a creatinine kinase to see if that is elevated. And I'm still trying to not sound ridiculous by just saying that I want everything, but I kind of, remain suspicious. Okay, so 1 second.
All right, we'll go back here for a moment.
Okay.
So we have sonographic evidence of myositis. a number of different idicities.
So more dermatitis, and again, some of these can go along different patterns, which again, alcohol can cause an acute myositis, which generally just resolves by refraining from alcohol, which generally happens in the hospital, although not always. It can be autoimmune, which could be worried about just checking like an ANA or like anti-synthetase things. We could be worried, is there some sort of like underlying other process going on? But really nothing about this looks like vasculitis or not having any rash or symptoms like that. And again, other things can be secondary to infectious etiologies, which we'd be more concerned about if there's any sort of solid thing there or elevated white count. We could still check for some subacute chronic infections for fun. Again, things like syphilis or HIV. We can make sure they didn't have a history of going north and potentially get some like tick-borne illnesses or things like that. But I am not too concerned about those. And then I have largely the other kind of abnormality that we've seen was the anemia, which I kind of have been assuming is most likely a chronic anemia, maybe in the setting of his alcohol use and not a new finding. I do see there is a tab for that, so now I'm thinking about it again. But that we could just make sure that he's reticulocytating appropriately and not deficient in nutrients, which of course is also common alcohol use.
Yeah. So I'll point out, you had mentioned infections.
Yeah,
so I'll go through some of those immediately. Simply pointing out his respiratory pathogen panel was negative. He had a negative hepatitis panel. HSV was not detective. He did have detectable CMV, but there was no HIV or RPR positivity. So it didn't appear to be infectious. And this is just a serologic infectious evaluation. I know you actually specialize in a different form of evaluation that is more invasive. So that is not represented here on this infectious eval. And then pointing out, you had wanted to talk briefly about anemia. So I'll just point out to you that these labs were obtained during his inpatient stay. He was anemic in the 7s to 8 range. His ferritin was quite elevated. This was drawn concurrently with his right thigh abscess. But his B12 is quite replete. And just to point out to everyone that the word replete is an adjective that describes something being full of something. It actually happens to not be a verb. So you could say, I'm replacing someone's potassium to make them replete with potassium. But you technically don't replete people. They are replete or they aren't replete. And you replace or you don't replace. So that's just something a nephrologist told me once. But anyways, this person is replete with B12 after I wrote replete the patient's potassium in a note. I've held that one back for 4 years. So B12 is replete. The folate is within normal. The haptoglobin is normal. The LDH is elevated. They did not obtain a smear, but I just wanted to point out that was the anemia workup.
Yeah, and
probably wasn't that helpful to you.
Yeah, some non-specific things. Ferritin's elevated, but it could just be an acute phase reaction. It was in the thousands. You can potentially wonder of like HLH or something, but you would expect to have a more systemic response in that situation. And then the LDH was a little bit elevated, but again, we know that cells are dying, or we believe that cells are dying. And so it's nothing crazy there and doesn't have evidence of hemolysis. So that is helpful.
Right. So I know now we have a little bit of the anemia, a little bit of infectious evaluation, but it does sound like you're tending towards, is this something autoimmune? Is it, an endocrine, kind of an endocrine dysfunction or a lack of nutrients? And then I know we have this joint effusion as well. And then, there are advanced imaging techniques that we can also turn to.
Okay. Wait, we do actually have a joint infusion?
We have a joint infusion now. Yeah, the effusion has appeared over the last couple of days.
Oh.
Yeah.
Well, that's nice.
Yeah.
Okay. So again, I can think of a million things again that we can test, but largely I would only order them because I'm at CPC and not so much because I was necessarily actually looking at the patient. So I should probably refrain from doing that. If he has an infusion, I think we should tap the effusion. I think that we should send any fluid that we collect for some studies, maybe a gram staining culture, maybe some counting of the cells, maybe looking, just because we're doing it and it's fun to do, look, make sure there aren't any crystals or anything, although that's not really what I'm worried about with his thigh.
Awesome. And then just to point out to you, what would be the most common approach if you're to do an arthrocentesis of, say, the left knee? What are the common approaches that you would use?
Well, I'm so glad that you asked. There are, of course, two main approaches to arthrocentesis of the knee, one of which is the bent knee, and the other is the extended knee. The bent knee is what I normally teach residents because it's the most straightforward and direct. However, if someone has a significant infusion of their knee, they oftentimes cannot bend their knee to 90 degrees, and therefore you should not use that approach because you can't do it. So then you must do the extended knee, which has the cool fact that you are actually aspirating from the infrapatellar bursa, but that directly communicates to the true knee joint itself. So if you aspirate one, you're aspirating the other.
Great. All right. This is great. No comment. I an expert at work. So we did a left knee arthrocentesis. The color was yellow. It was clear. The gram stain did not demonstrate anything, and the culture showed no growth. We're jumping forward in the future. Now we'll go back. There were 38 nucleated cells, 8 neutrophils, 790 RBCs, and the crystal analysis was negative.
And do you know how much volume they took off the knee?
Do
you know how much volume they took off the kney? You don't have to.
I think it was like 15 or 20, but I don't remember exactly.
Yeah.
How would that influence you?
Yeah, and so here again, we're pretty non-specific. We don't see a super high neutrophil count that we'd expect with acute septic arthritis, but we're not also really worried for acute septic arthritis. There are a bunch of red blood cells which may or may not have been introduced by us attempting to do the neocentesis. And white hem synchronicity, there are some lymphocytes could imply that there maybe, again, is some kind of more chronic inflammation going on, or might just be, bland.
Awesome. So there also was some neuromuscular testing, just to point out, because there was weakness earlier in the hospital stay. And they did a neuropathy panel and then checked, and there was, just so you know, some evidence of axonal sensory neuropathy that was present for this patient. Okay. It was non-specific.
Yeah. So far, we are going through a whole bunch of non-specific things. And I think that if we did additional lab testing, is likely to still come back as additional non-specific things. Again, this is more focal. Again, for a room, we could still check like an ANA. We could check for like the anti-synthesase antibodies that are common in immune-mediated myositis. For endocrinology, when I'm thinking more about like myopathy, I'm thinking more like, things like chronic adrenal insufficiency and things like that I'm not really worried about in this acute setting. And then for advanced imaging, because I have not yet found other things, it is reasonable to say our ultrasound was great, and it did tell us that things were swollen, but otherwise did not really identify anything there. And maybe if we look harder, we would find something that we could biopsy or look at further.
Yeah, I agree. So we'll move through in kind of the stepwise fashion, getting over to the advanced imaging in a moment. We'll talk about the room serologies that were obtained. So this is what we see. So we see an elevated aldolase. CRP and ESR are elevated. The CK was checked multiple times throughout the admission. This was the one that was the most elevated. Some of them were in the upper range of normal. ENA was negative, antihistone, JO1, CCP were all negative. They obtained a uric acid, which was also negative. And then just to point out, the ANA was also negative. So kind of their rheumatologic room was consulted. They recommended these labs, but their team was ultimately not the one that clinched this.
Yeah. And we see overall relatively mild elevation of creatinine kinase. Aldolase is relatively speaking more elevated, but again, showing that there is some muscle damage, but nothing more that you couldn't do with attempting to do some brisk running or things like that. And then the inflammatory markers, that's because they are relatively elevated, which again does not necessarily narrow us down between, yes, common autoimmune conditions, also common with inflammation in general, of other etiologies.
Yeah. So going back to the rest of this, I'll point out some endocrine, we'll do some nutrient labs here, and then we'll probably transition to some advanced imaging. So pointing out to you that the A1C, mostly contemporaneous to this, was 7.2%, consistent with your diagnosis of type 2 diabetes.
Thank God I got that.
I will say that this was likely influenced by quite good glycemic control during this patient's long hospital stay. And recently, this patient's been admitted with an A1C of 10.5%, indicative that usually this patient is not well controlled in their type 2 diabetes. They checked a TSH, which was within normal, and then they did another number of other nutrient labs, which I will put out here, none of which were ultimately the most illuminating, other than this vitamin D deficiency that it's not as low as mine, but I'm also vitamin D deficient. But this isn't about me.
Yeah. Yeah. So again, relatively benign, just low vitamin D. Everything else is normal. For most, again, of the things that I'm worried about with vitamin deficiencies, I'm not expecting to be more localized to the thigh. People, I mean, he was just drinking a lot of alcohol next to another food. You could get a whole bunch of other things, like you get scurvy, but again, that'd be more diffuse and skin findings and all that fun stuff.
Yeah. So what's evolving here is a patient who has evidence of myositis that seems quite localized in the left thigh. We have evidence of myositis or some other form of itis. We're not seeing anything specific on rheumatic etiologies. We do have a clear presence of diabetes. We're not seeing anything really infectious right now either. So we're turning to our advanced imaging. So the first thing that they obtained was a CT of the femur with contrast. And this showed this hypoattenuation of the left quadriceps muscles that could represent edema and or atrophy. They did not see a discrete fluid collection. There was a large left knee joint effusion, which we have tapped. Pointing out also that on exam, this patient did seem to have a little bit of decreased muscle mass in the lower extremities. There was some thought maybe that this was critical illness, but they also just overall noticed that there was some decreased muscle mass that's consistent on this exam. And then there was an MRI done that also was of the pelvis, but most notably, we see this anasarca and diffuse myositis, and there is myonecrosis within the left quadriceps and the left vastus intermedius and medialis, and then they also see some myositis in the medial right thigh. With this big new finding here of the myonecrosis that is within the left thigh musculature, a focal point of myonecrosis.
Yeah. So I'm still struggling a bit. Now we are also seeing concern for some kind of bilaterality or potentially spread. Yeah. So left quadriceps musculature, myonecrosis. Again, I guess I'm still puzzling a little bit about the focal presentation of it, which normally I would think of more of some sort of local injury, be that either an infectious process or, after like a bite from a animal that produces toxins. And more of my kind of like systemic myositis and things like that. Myonecrosis.
So things that we're pointing out that I'll kind of reframe because we've covered a lot of information too, and we also have some pathology that is consistent with this. Thinking about this patient, kind of reframing as we often do during our admission. So we have a patient who comes in, they have this kind of longer admission due to the right thigh abscess, antibiotics. They have this new kind of acute finding of the left thigh pain, which is also associated with an effusion. The patient does not have a leukocytosis. They have type 2 diabetes. They also have peripheral neuropathy. We're not seeing any evidence on the rheumatologic labs of seeing anything highlighting like a polymyositis or dermatomyositis or inclusion body myositis. We don't see anything like that. And then we do have this new finding of myonecrosis that's present in the deep muscles of the thigh here. We also have some, you could describe a little bit of muscle loss that may be related to some nerve damage as well. That's consistent with the peripheral neuropathy that we have, maybe from the type 2 diabetes, with a little bit of help from alcohol that likes to destroy things.
Yes. So we have all those things going on. And then, yeah, so there's some component with this kind of prolonged illness of lower down. You can have atrophy things. You can have denervation from lots of things, which again could be related to diabetes and alcohol, or it could be one of a million things that are technically on like peripheral neuropathy lists, most of which we don't have anything that we can do for. Okay.
So coming back, they consulted ACCS early in the admission. They said, not us, not it, and then they signed off. And then they did obtain pathology, and the pathologist is not here today, but I'll just simply tell you that their pathology was relatively nonspecific, but they see marked reactive changes, myonecrosis throughout all the tissue. They're not specific for an etiology, but they didn't capture, any nerves or anything. This is just 3 core tissues of muscle that were all necrosed. Which we saw in the MRI.
Yeah. So we have a like dead inflamed muscle. Okay.
So I'll run through, our stuff. So we have our MRI showing myonecrosis. We have our pathology showing myonecrosis. We have the definite presence of our type 2 diabetes, some alcohol use, but that hasn't been present for weeks, almost months at this point. Rheum was consulted, endocrinology was consulted, and those 2 teams kind of debated the patient throughout. And then, sorry. So those two teams kind of debated the patient, with Rheum signing off.
Oh my goodness. Okay.
The main consultants at this time were endocrine and rheumatology.
Okay. I guess I'm just seeing, I still do not know why this muscle has become necrotic and why it is swollen and inflamed.
Yeah. Yeah, more mild versus we have muscle cell death, perhaps infarction.
Yeah. So one is more severe and oftentimes more associated with a more acute event, which could be something that cuts off the blood supply, which can be, arterial venous, can be just straight up due to trauma, can be secondary to like a compartment syndrome, and can be the result of just a more severe, like untreated myositis that then progresses to the point where things become inflamed enough that cells are dying. So here he was in the hospital for a long time. There's question of, is there something that would have happened that would have caused one of those processes? I don't really hear a history with that. And I'm having, I guess, definitely connecting if there was that process, why it would also then cause like a knee effusion, which I think is more reactive, generally something more specific to the joint, which again tends to be infectious and autoimmune things. I don't know. We can look at we could do a CTA to the area to see how his blood vessels look. But I do not have a great answer.
Yeah, no, the vasculature was all patent when they assessed that. So kind of thinking about this person, I'll tell you a little bit more about their hospital stay and how it continued on. So let me get here. So thinking a little bit about their hospital stay as it went along. So the patient's hospital stay was about over 2 months long. It was initiated by this transfer for a right thigh abscess. He had AKI, encephalopathy, acidosis. He had a bradycardic arrest, hypoxic respiratory failure, weakness, bacteremia, AKI, and CKD. For this specific problem, he worked with PT and OT, had a multimodal pain regimen. His weakness required assistance at home health PT and OT, and required some durable medical equipment because there was no specific treatment for this myonecrosis that was going on. The only medicines that were allowable would have been contraindicated based on his AKI and CKD. He continued to be chronically ill. Right now, this person has ESRD on HD. He also has heart failure. He was recently admitted in the last month for empyema and sepsis, and has had very poor diabetic blood sugar control.
Did he have hypoperfusion during a bradycardic arrest, or was that distant to this presentation? I don't.
So that had
I'm
occurred
just-
about, this is wild to say, but about a month and a half before this. He had been inpatient the whole time. So they didn't attribute it to this, but on a microvascular level, there is evidence that the etiology causes denial of blood flow to the muscles, kind of small blood vessel infarction, and then myoinfarction and myonecrosis. They can also affect the nearby nerves. There's some overlap here that could also cause kind of loss of muscle mass in the lower extremities or affect the hip girdle. And in its minimal elements.
And it's what?
Hmm?
Okay. Yeah. And so he has been chronically ill for a long time, and with the, I guess, there and with kind of you also hinting earlier with the endocrinology team being on board, that could make you, I guess, worried about kind of prolonged critical illness causing, again, something like adrenal insufficiency, which can also happen after an element of hypoperfusion if that kills your adrenals. They previously, I think, said that they did check thyroid function and that was normal.
Adrenal function ended up being normal.
Okay.
So they were focusing more on the blood sugar control.
And blood sugar does many things. I don't normally think of diabetes as causing myonecrosis, because, okay.
It would be rare.
Yeah. What it?
It would be rare.
How rare?
Rare enough.
Really?
So let's give a round of applause to Dr. McDonnell for diabetic myonecrosis. Early on, identified the type 2 diabetes, worked through a broad differential pointing out many factors of this hospital stay. He did a great job. Thank you so much for your great job walking us through all of your thinking, which as an outpatient physician, you should always consider outpatient versus inpatient for thigh pain. We thought about systemic illnesses, inflammatory systemic illnesses, as well as direct trauma or infarction, broad workup, and then honing down in as the number of possibilities limited itself more and more down to the diabetes, which ultimately through very long attestations from the multiple different teams said this is an extremely rare event, which we very often do not see, but diabetic myonecrosis. Dr. Oslin's note said, there could be overlap with diabetic amyotrophy. So just pointing out a little bit, there are kind of these three elements of diabetic complications. The myonecrosis, which is this infarction of muscle, usually with significant pain, some serum evidence of myonecrosis and imaging. Amyotrophy, the infarction of the nerves. This often occurs around the hips and thighs, kind of the nerves going through the hip girdle, and there is pain and muscle loss. The diabetic neuropathy differentiates itself from the polyneuropathy because it affects a single nerve, like the lateral femoral cutaneous nerve or potentially cranial nerve 3, which causes ophthalmoplegia. It's usually painful and resolves over months. But this myonecrosis, this was hidden a little bit because the A1C was only 7.2% when we talked about him. It often affects the thigh, though this is an extremely rare diagnosis. You identify in an exam and serum, CK may be being elevated, potentially normal. MRI will show myonecrosis. Treatment is conservative, usually is reliant on NSAIDs, which was limited in this patient with AKI and CKD. You avoid exacerbating activities and exercises, and then basically your only bet is improved blood sugar control, which unfortunately this patient did not achieve. So thank you so much, Dr. McDonnell.